Good morning or afternoon, everyone. My name is Destiny Kelly, and I'm the Learning and Development Manager of the NNPTC National Coordination Center. In today's webinar, we'll focus on TM7. In our time today, we will have 1 hour of content and 15 minutes of Q&A. The NNPTC is made up of 8 regional prevention training centers, known as the PTCs, and 2 national centers, including the National STD curriculum. We are funded to train clinicians in the diagnosis, treatment, and prevention of STIs. Each PTC also provides technical assistance to clinics and health departments. The STD Clinical Consultation Network is a free online system where clinicians can submit complex STI questions, and an NNPTC experts from one of our PTCs will answer in 1 to 5 business days by phone, email, or text. There is a feature to upload non-identifying images to STD-CCN for assistance in lesion identification. The National STD Curriculum is a free, up-to-date educational resource for healthcare professionals to learn about the diagnosis, treatment, and prevention of sexually transmitted infections. The planners, speakers, moderators have no disclosures. To receive CE, you will register and attend the virtual course. The post-course online Complete the post-course online evaluation. You will receive a link at the end of the day today. Please check your spam and complete that within 2 weeks. You will be notified via email that a certificate is available in your NNPTC portal in 4 to 6 weeks after the event. Our speakers today are Dr. Irina Kasarkis, an epidemiologic Intelligence Service Officer with the Mycotic Disease Branch at the Centers for Disease Control and Prevention. She obtained her Doctors of Public Health and Epidemiology from Colorado School of Public Health and an MPH in Biostatistics and Epidemiology from Boston University. Dr. Jason Zucker is an adult pediatric infectious disease physician and assistant professor of medicine in the Division of Infectious Disease at Columbia University Irving Medical Center. Dr. Zucker focuses on sexual health and adolescent community, both clinically and in research, and he serves as the New York City PTC Assistant Medical Director. Emily Silva is a PhD trained epidemiologist currently working as an Epidemic Intelligence Service Officer at the Minnesota Department of Health. She is leading the outbreak response for TM7 in Minnesota. Our Q&A moderator today will be Dr. Laura Quilter. She is the clinical team lead of the CDC's Division of STD Prevention. Without further ado, I'll turn it over to our speakers.
Hi, thanks so much for having me. Today I'll be covering a brief introduction to trichophyton metagrophytes genotype 7. I'll be referring to it as TM7 throughout the rest of my presentation. All right. So let's start with what is dermatophytosis. It's also known as tinea or ringworm, and this is a group of contagious fungal infections that affect the skin of both humans and animals. We often think of this as a mild infection that's treatable with an over-the-counter topical antifungal medication. Lesions are typically located on the trunk and extremities, scalp, feet, and groin. Sorry, my slide's not advancing. We'll see. Okay, great. So ringworm can be transmitted in 2 different ways. The first is through direct contact. So think about skin-to-skin contact with an infected animal or human. The second is through indirect contact with a contaminated surface. So think about something like a towel or a shared surface in a gym or locker room. So why is TM7 different from just a standard dermatophytosis infection? TM7 is often a more severe and inflammatory disease on the genital and perigenital skin. This can have painful and persistent lesions with a risk of scarring and secondary bacterial infection. This shows up in our classic ringworm. While you can have lesions that show up on the groin, the lesions typically don't show up on the genitals, whereas with TM7 it does. So TM7 may be mistaken for a bacterial STI or other skin conditions due to the location and the inflammatory appearance. It's also really difficult to diagnose, and there's a couple reasons why this happens. If patients have used either topical steroids or topical antibiotics before they come in for testing, this can mask the typical presentations and features of dermatophytosis. It also has some diagnostic complexity. You can't just do a simple routine culture, and you typically need to use molecular methods such as whole genome sequencing in order to determine what the species is. And I want to caveat that this is a long process and can take several weeks until you have your answer. TM7 also has prolonged treatment. It typically requires systemic antifungal therapy for at least 1 to 2 months, and sometimes that can even last longer for some patients. It's important to note that you can't use topical antifungal therapy in areas where there are lesions that have hair follicles because the medication won't actually penetrate through the hair shaft. So let's reflect back in time. And when do we start becoming concerned with sexual transmission of dermatophytes? One of the earliest papers that we have comes in 2002 from Otero and colleagues, and they had a case series that involved 7 female sex workers. A little bit later, another group also published a paper among female sex workers in Nigeria, and they noted that there was a higher than expected diagnosis of dermatophytosis in this population. As we move forward into 2014, the first reported sexually transmitted TM7 cases in a cluster from Zurich were reported. Note that all of the patients in this cluster presented with lesions first in the genital region, and many of these patients reported frequent shaving in the genital area, and this may have disrupted the skin barrier, allowing for easier transmission of TM7. In this cluster, 3 cases recently reported travel to Southeast Asia where they had sexual contact, including contact with sex workers. In 2016 to 2017, we started to see 37 suspected sexually transmitted TM7 cases coming out of Berlin, Germany. This is in both male and female patients, and only 4 of those cases reported recent travel to Southeast Asia. So since 2021, both France and Germany have reported over 20 cases of sexually transmitted TM7. In Spain, Italy, Greece, and the United Kingdom, those countries had fewer than 20 cases of sexually transmitted TM7. And we really have started to see a change in who is acquiring sexually transmitted TM7. 98% of these cases were reported in men. And when we had data available about their sexual partners, the majority were men who have sex with men. This has opened up the possibility of local transmission in Europe. Our molecular epidemiologic analysis also supports this hypothesis. More recent TM7 strains from cases that were recently reported in France and Switzerland were starting to show distinct differences from those that had connections with travel in Southeast Asia. So next, we're going to jump into an interesting paper that came out of France. And this is summarizing the TM7 infections from 2022 to 2023. So there were 15 cases that really didn't have any clear epidemiologic link, but we had a really interesting cluster that came out of this analysis. We have one index patient who was a tantric masseur by the occupation. He only had male clients, and a session with him involved full body skin-to-skin contact. After the session was completed, linens were regularly changed and washed at a high temperature. On April 15th, our index patient started to develop several lesions, more than 10. He continued to provide massages to 19 more individuals up until April 27th, 2023. Of those clients, 18 showed up with similar lesions, and something else started happening. We had 4 clients who had an appointment before he developed lesions, and they also started showing up with similar lesions. So from his clients, we ended up with 15 who had confirmed TM7. His roommate, where they had no skin-to-skin contact, but they occasionally shared bathroom linens, developed a single lesion on his back. And there are some pictures from some of these patients to the right. In the United States, we had our first identified case in 2024 from New York. This case reported recent travel to Europe and also within the United States and had multiple sex partners while traveling. In 2025, we had cases reported in both Minnesota and Colorado, and some of the similarities we saw among those patients were among people who have multiple sex partners, people who are living with HIV, people who had concurrent STIs, people who used meth, and some international travel. So when we're looking at, oops, I jumped ahead there. So when we're looking at the common populations that we've seen reported in the United States, as well in the literature that comes out of Europe, we're seeing TM7 most commonly happening among men who have sex with men with multiple sex partners, people living with HIV, people on HIV PrEP, and people who have other STI co-infections. So moving ahead, what do we think about for preventing further transmission and what should we recommend? Ideally, we would recommend avoiding any skin-to-skin contact, such as intimate or sexual contact involving the impacted area until the lesions have fully healed. And remember, this can take several months. So if that's not possible, make sure to cover the lesions with a bandage or clothing to prevent any unintentional spread. It's also important to remember to avoid sharing personal items and clothing like razors, sex toys, and linens. And then finally, remember to wash clothing and linens on high heat so you can kill any remaining fungal spores. So at this time, TM7 is not a nationally notifiable condition. In collaboration with CDC, the University of Alabama at Birmingham has developed a case registry where clinicians can share information about suspected or confirmed cases with the goal of gaining a better understanding of TM7 spread in the United States and its impact on other populations. The American Academy of Dermatology also has created a registry for drug-resistant dermatophytosis, and this can be of any species. So we strongly encourage, if you have a patient that would fit into either of these registries, to please report it so we can continue to learn more about what's circulating in the United States. And I'll close out by saying that we are still actively learning a lot of stuff about the epidemiology of TM7 infections, what the best practices are for treatment and prevention. And I'll give a little plug for our lab. If you happen to have an isolate from a TM7 patient and would be interested in having it sequenced, we'd love to have that. And so we can continue to learn more about what strains are circulating in the United States. This would not be diagnostic or clinical testing. So that would be really helpful and we'd appreciate it. So if you have a concern about a potential outbreak or want us to connect you to our lab, please reach us at fungaloutbreaks@cdc.gov. And if you have a really specific clinical question and that's a more helpful avenue, we have another email account, fungalconsult@cdc.gov, that we'd love to connect with you in either way. So at this point, I'll turn it over to Jason. Thank you so much.
All right, fantastic. And thank you so much for that great introduction. And thanks so much for everybody joining us today. It looks like we have a fantastic attendance. And so my job is to talk about some of the clinical aspects of TM7. And as always, I like to start with a case. And as always, this case is based on a real case from our sexual health clinic. So this is Trent. He's 22 and has been coming to our sexual health program for quite a long time. He's sexually active with men and regularly attends sex on-premise events most weekends. For HIV prevention, he's been on PrEP for about 5 years and recently switched to long-acting injectable PrEP with lenacapavir. And then because he's had gonorrhea and syphilis in the past year, he was actually started on doxypep about 6 months ago. So Trent walks in with a pretty common complaint for us, but it's the kind that can go in a lot of different directions. He reports that he had a pretty generalized, intensely itchy rash on his abdomen, extremities, and genitals, going on for about 5 days. So looking at these lesions and thinking a little bit like a dermatologist, they might describe these as scattered, multiple round erythematous plaques on the trunk and extremities, with peripheral scale, and a more active raised scaly border in places, as well as some central clearing, particularly on this one on the arm here. So we have our history and exam findings. It's time to start thinking about our differential. So obviously today's talk is all about TM7, but what else should you be thinking about right now? What else is high on your differential? Destiny, I can't see how many people have voted and when it's slowing down. Sorry. All right, so we have our differential here. People are thinking about tinea corporis, secondary syphilis, nummular dermatitis or eczema, psoriasis. Excellent. So all these things should be on our differential because we won't always know that it's TM7 because we won't always be in a talk about TM7. Um, There we go. So I made this chart to really think about what would be on our differential if we saw when we saw this patient in our clinic. I won't go through everything on this slide, but we'll make sure to make these slides available after the talk. You know, in terms of TM7, I think about things that are really itchy. It often has genital involvement, and it's frequently more inflammatory than our regular tinea that we see. It can sometimes be pustular and sometimes follicular, but it's definitely more inflammatory than we're used to. We do also want to think about other types of trichophyte or other dermatophytes where you can get those annular scaly plaques with central clearing, but they tend to be less inflamed, less angry appearing. Classic tinea corporis has a raised advancing border and scale, which is a little bit different. Secondary syphilis, we think of it most commonly as a papulosquamous rash. It can involve the trunk, can involve the palms and soles. You can have systemic symptoms like lymphadenopathy, but not to forget that secondary syphilis really is the great imitator. And we've all been fooled numerous times where things that didn't look like secondary syphilis turns out that they were. Candidiasis most frequently happens in moist erythematous areas like in the groin. You often see satellite pustules in intertriginous areas. One thing I will say though is if people use the topical or over-the-counter steroid cream, then candidiasis can get much worse. And I actually had a case recently that really looked like TM7, but it turned out to be just candidiasis in a patient who had used topical steroids that really made it sort of explode all over and look much more inflammatory than we may have expected. Nummular eczema presents with coin-shaped pruritic plaques, but the scale and border looks pretty different. Psoriasis has some typical locations in a silvery scale. As we're putting more and more people on doxy-PEP, we need to think about drug eruptions. However, these are usually symmetric, and they're often temporally related to when people are taking the medication. And finally, pityriasis rosacea can look very similar, generally with a herald patch on the trunk and then the rest. And so the differential for someone coming into sexual health clinic with a rash is really quite wide. So with such a wide differential, what would you do next? What would be your next thing? We'd obviously do many of these things in clinic, but what would be the next thing you would do? And Destiny, just let me know when it slows down.
All right, getting the last votes in here.
All right, so about 50% of people would get a fungal culture next. And I'll say that that's what I would probably do as well. About 30% would start a topical antifungal, very reasonable, something to think about. About 10% would start fluconazole, 6% would start terbinafine, and 4% would start topical steroids. All right, so we're going to talk about all of these different options right now. I would probably personally start with the fungal culture. And the reason for that is that fungal infections actually take a long time to culture. And so while you may not delay empiric therapy, you may start empiric therapy, it's actually important to make sure you get that culture up front, especially as we see more and more of these harder to treat dermatophytes. If you get the culture up front, then if something happens and the patient's not improving, you then don't have to start with the culture then. You already know what the patient has and how to deal with it. So this is how we work up fungus or diagnosis of dermatophytes. Again, we should not be forgetting about other things in our differential. We should still be sending our RPR for syphilis. We should be thinking about drug eruptions. But, it starts with a clinical diagnosis like we did here. For some sites, they can do a point of care KOH prep can be really helpful. If you see hyphae, great. That really supports the diagnosis of fungal infection. But just remember that it's not a very sensitive test, and a negative KOH does not rule out fungal infection. The biggest thing we can do is lab diagnosis, and this includes fungal culture. And in the emerging dermatophyte era, especially includes antimicrobial susceptibility, as well as potentially DNA sequencing. There are two emerging dermatophytes that we'll talk about, TM7 and Trichophyton indotiniae, that actually you need DNA sequencing to be able to separate the two. And these can have treatment and public health impacts, which is why it's so important to make this diagnosis. Zooming out for a second, and one of the reasons this webinar exists right now, you know, there are three emerging dermatophytes in the United States at the moment: Trichophyton indotiniae, TM7, that's the focus of today's talk, as well as terbinafine-resistant Trichophyton rubrum. And clinically, there's a lot of overlap between these three, which is really part of the problem. From a management standpoint, when we get to treatment, you'll see we don't treat them all the same way. And that's one of the reasons it's so important that we start getting routine fungal cultures when patients present, so we can identify what dermatophyte it is and know whether we're providing optimal treatment or not providing optimal treatment. So going back to Trent to see how this plays out, we sent diagnostic testing, and our fungal culture did come back with the diagnosis of TM7. I will say that we are very lucky in that our lab can do sequencing. Many labs may report things like TM complex or trichophyton species, depending on their methods. And so not everyone will get the full diagnosis of TM7 right away. But now that we know the diagnosis, I do want to go back to our differential. Thinking about what we saw that pushes us towards TM7 versus what would push us towards other diagnoses. Probably the number one thing right now is that TM7 tends to be sexually associated. It often involves the groin, buttocks, or genitals, and looks more inflammatory than other forms of tinea. I'm going to skip over most of this slide today, but I'll make it available to you so you can look at sort of how these things differ from TM7. One thing to always remember, though, is that none of these read the textbook. Frequently we'll see morphology that's not classic or is not responding in ways we expect. And that's really why it's so important that we do a full workup. We do cultures to help us understand, especially in some of these atypical or unusual cases. So, about a third of people wanted to start empiric therapy before, but we started first with our fungal culture. Now the question is, we're going to offer empiric therapy. What should we offer? We know he has TM7 in this case. What should we treat him with next?
Getting those last votes in.
All right, so about 45% of people said terbinafine, which is going to be the right answer, but I'll tell you why in a second. About a third said a topical antifungal, and about 20% said fluconazole, which is often the antifungal of choice for ID doctors. And we're going to tell you why today that's not the right answer. All right, there we go. So first line therapy for TM7 is terbinafine at a dose of 250 milligrams daily. And the duration is going to be longer than you think, generally at least 4 to 6 weeks, and sometimes even longer if there's follicular inflammatory disease, genital buttock and beard involvement, or prior treatment failure. We generally actually need to evaluate patients while they're on therapy, and we actually want to treat them a couple of weeks past when all the symptoms resolve. Our alternative therapy is itraconazole. We generally reserve itraconazole for a poor response or intolerance to terbinafine, or when there's concern that you're dealing with a misidentified species, especially Trichophyton indotiniae, where you frequently need to use itraconazole for treatment. Whenever I say this, people always ask why not use itraconazole for everyone? Well, there's some issues with variable absorption. There's definitely some drug-drug interactions with the HIV population. There's more monitoring burden, and there's no evidence of superiority over terbinafine for TM7. So again, we generally recommend starting with terbinafine and then only switching to itraconazole if you either are concerned about the diagnosis being correct or if the patient is not responding to terbinafine. There are also some things you probably should not treat with. The first is fluconazole. In ID, we often first think about fluconazole because we often treat a lot of Candida species. It's not that fluconazole is not active against dermatophytes. but it's actually pretty unreliable for its use. It doesn't penetrate keratin as well as we'd like, and we don't have outcome data supporting it in TM7 cohorts. So it's really a setup for partial response and inadequate therapy. I don't have it on this slide, but also topical antifungals are not recommended as monotherapy. They don't effectively penetrate the hair follicle, and some of the case series out of Europe just did not demonstrate a good response. So if you want to use topical antifungals, you can do that in combination with terbinafine, but not in place of oral antifungal therapy. The thing we need to be avoiding are topical steroids. This is the big pitfall. But steroids can blunt inflammation and make things look better, and they can also make people feel better even as the fungus continues to expand. This is classically called tinea incognito and can make these infections look much, much worse, leading to increasing pain, discomfort, and scarring. And so it's really easy to offer steroids when people are uncomfortable, but we want to actually try our best to avoid giving steroids in these cases. Another great example of why it's so important that we know about this disease and that we make an effort to culture it and avoid giving steroids. So how long should we treat for? So we're going to start with terbinafine, and how long are we going to prescribe it for?
Get those last votes in.
All right, very happy to see that 57% of people said greater than or equal to 6 weeks. 28% said about 4 weeks, which may not be the wrong answer. 2 weeks and 1 week are definitely too short for this emerging dermatophyte. So we really have limited data, and it's based on the cohorts that have come out of Spain, France, and New York City. But this is what we know. In the 2 week or less course, there was essentially no cure. Relapse was basically universal, and so it's not going to be adequate. At 3 to 4 weeks, you often see clinical improvement. Patients feel better. The rash looks calmer. But cultures can still be positive, suggesting the possibility of transmitting still. And relapse risk is high, especially because the culture is still positive if you stop here. 6 to 8 weeks or more, this is where you see the highest cure rates, and relapse becomes much more uncommon. Clearance can be really slow, but it's durable and lasts. People are not getting relapses when we're treating them for longer and longer. One thing I'll say is that, in this case, picking a number for duration is not enough. TM7 really should be treated until the lesions fully resolve, and that requires ongoing follow-up with us in our clinic. There is some residual hyperpigmentation in some patients that can make it really challenging to figure out when patients have resolved. And our goal is ultimately to continue oral therapy for about 2 weeks after symptom resolution to ensure a complete cure and reduce the risk of relapse. There we go. So this table goes back to our three emerging dermatophytes. Trichophyton indotineae is often travel associated, specifically to Asia. There is some local transmission now reported in the United States, which is why I bring it up here. And it's frequently terbinafine resistant. So if you treat with terbinafine, you may get failure. Itraconazole is typically the treatment of choice and prolonged. So if you have a patient with TM7 who's not improving and you didn't have DNA sequencing, it's possible that they actually may have endotineae and may need itraconazole. We talked about TM7 already. It's very common among gay, bisexual, and other men who have sex with sexual networks with significant genital involvement. It's generally terbinafine susceptible, requires prolonged terbinafine treatment, and if we stop too early, we know that we see high rates of relapse. The last thing I want to mention is terbinafine-resistant trichophyton rubrum. It's sporadic but emerging, and it's important because it's terbinafine resistant. So again, for a person who's not responding to terbinafine, you may want to consider switching to itraconazole if they're having failure. So in this case, we can just use the Q&A, but actually we talked about this a little bit before. We'll skip the question here, and I'll just talk a little bit about transmission. When counseling about transmission, there's some things that we do know. We know that TM7 can be transmitted through close skin-to-skin contact, including sex. We know that the lesions often involve the genitals, buttocks, and face. We know from some of the great DIS work done in Europe that transmission can actually occur before the diagnosis is made. And cultures can remain positive for weeks even after starting treatment. So early in therapy, you may still be able to spread it to your partners. Here's how I counsel patients during treatment. I talk about avoiding skin-to-skin contact involving the affected areas, especially friction over lesions. So trying to engage in sexual activities that don't involve the areas that are infected with TM7, or making sure those areas are fully covered during sexual activity. And avoiding sharing towels, clothing, bedding, and grooming items to avoid transmission. After treatment, it's very unusual for occurrence to be related to reinfection. If it comes back, it usually means we stopped too early, not that patients were reinfected immediately. And that people should let their partners know if they develop similar rashes to try to bring them into clinic as soon as possible and get treatment. This is just a summary of what we talked about today. What is TM7? It's this emerging dermatophyte with sexual transmission that's circulating in gay, bisexual, and MSM networks in the US and Europe. It's often misdiagnosed as a bacterial STI or inflammatory dermatosis. It's different because it involves the genital area. It's different because it's more inflammatory. And it's different because it requires longer treatment than we're used to with dermatophytes. It means that we do want to make an effort to try to culture dermatophytes whenever we can. We want to think in our sexual health setting about treating upfront with terbinafine, 250 milligrams daily, and treating until lesions fully resolve. And if the lesions are not resolving, we want to follow up our cultures and see if we made them misdiagnosis or consider empirically switching to itraconazole because it could be terbinafine resistant. And we want to counsel patients that this is transmissible and think about a harm reduction approach to transmission. And with that, I will turn it over to the next speaker and thank you all for joining.
Okay, great. Thank you so much for having me. I am going to talk about the response to a cluster of TM7 cases identified in Minnesota during 2025. To tell the story of how TM7 was first identified in the state, I will start with the first two patients. I'll share these cases not to get into clinical decision making or treatments, but to illustrate how a case might present at your clinic, to mention potential misdiagnoses, and to demonstrate the power of an astute clinician. So patient A presented to an STI clinic in Minneapolis in May 2025. The patient is male and in his 40s. His chief complaint is 4 days of itchy, painful rash surrounding his anus and scattered on his wrist, thigh, and abdomen. He requests STD testing. Sorry. Let's try to go backwards. He requests STD testing. He's living with HIV and on antiretroviral therapy. He has a history of substance use disorder and reports recent unprotected sex with multiple partners. He reports sexual activity with men. The diagnosis responsible for the lesions is unclear. The infectious disease doctor ordered tests for syphilis, herpes and varicella virus, and Mpox. When a dermatologist was consulted, they suspected a chronic skin condition and recommended topical steroids. Patient A was treated empirically for syphilis pending additional workup. Syphilis, HSV, and Mpox all came back negative. 1 week later, patient A messaged their clinical team reporting a partner had been diagnosed with jock itch and requesting treatment for ringworm. The infectious disease doctor thought this was odd and recalled seeing an emerging infections network post about sexually transmitted ringworm in New York City. She prescribed topical terbinafine. 1 month later, patient A returned for a follow-up appointment. The patient's lesions were improving. At this point, the doctor had seen a second patient with similar lesions and suspected this might be TM7, but patient A's lesions no longer had overlaying scale for specimen collection. The patient continued treatment with topical terbinafine until resolution. Patient B presented to the same STI clinic in June 2025. The patient is a male in his 50s. His chief complaint is 2 days of a new rash in his groin. He requests STD testing. He's living with HIV and on antiretroviral therapy, and he has a history of substance use disorder. The patient reports a new sexual partner 3 days ago and reports sexual activity with men. Patient B was initially seen for a nurse visit and was treated empirically for syphilis. The patient was instructed to return if the lesion didn't improve. The patient returned to the clinic 1 week later after no improvement and mentioned partners had been diagnosed with jock itch. The patient had started over-the-counter clotrimazole a day earlier after his partner mentioned ringworm. So the infectious disease doctor suspected TM7. She watched a video online to learn how to collect a skin scraping, and she sent the specimen for fungal culture. The patient was instructed to continue the topical antifungal with a plan to switch to oral antifungals if there was no improvement. The patient returned 1 week later, reporting minimal improvement and a new lesion on his finger. At this point, the infectious disease doctor was pretty sure this was TM7 and prescribed oral terbinafine. The fungal culture grew Trichophyton mentagrophytes, and the provider worked with the Minnesota Department of Health to get the isolate sent for genotyping. A month later, the patient was confirmed as the first TM7 case in Minnesota. So the first 2 patients were seen by Dr. Huseman, an infectious disease provider in Minneapolis. After suspecting TM7, she contacted the state health department for help coordinating confirmatory testing. The isolate was sent to Wadsworth Center in New York State, and genotyping confirmed the first TM7 case in Minnesota at the end of July. In early August, MDH alerted STI clinics, infection preventionists, and infectious disease doctors in the state about the recent TM7 case. These alerts were sent out as digital memos to STI networks and via compendium to infection preventionists. The health department also updated infectious disease doctors on monthly provider calls. In September, local STI clinics and patient advocacy organizations worked on getting the word out through web and social media posts and continued to see patients with rashes consistent with TM7. Patients reported others in their sexual networks with similar rashes, and there was concern for ongoing transmission. The Minnesota Department of Health organized a meeting with CDC so local providers could consult subject matter experts. CDC shared that this was the largest cluster they were aware of in the US. And in collaboration with CDC and providers at local clinics, the Minnesota Department of Health initiated an outbreak response and investigation. We're hoping the data collected through our enhanced surveillance and patient interviews will help us understand more about the organism and transmission dynamics. This investigation is still in progress. So because TM7 is not a reportable disease, as part of our outbreak response, we set up an enhanced surveillance system for the state. In Minnesota, when a patient visits a clinic and a provider suspects TM7, the provider is encouraged to collect a specimen, either skin scraping or a biopsy, for fungal culture. The provider empirically treats the patient with oral terbinafine and reports the suspect TM7 case to the Minnesota Department of Health via phone or an online reporting form. If the fungal culture grows Trichophyton mentagrophytes, or TM, the isolate is sent to our state public health lab and forwarded to the Wadsworth Center for molecular characterization and antifungal susceptibility testing. Those results are reported back to providers and patients. Meanwhile, the Minnesota Department of Health staff review the patient medical records and complete a standardized case report form that was developed in collaboration with CDC. A disease intervention specialist contacts the patient to provide public health recommendations and conduct a detailed follow-up interview, which includes questions on potential exposures in the weeks leading up to rash onset. We created outbreak case definitions that allow for the inclusion of suspected cases without laboratory confirmation. So confirmed cases were defined as any patient with confirmed TM7 infection by culture and molecular sequencing. Probable cases are patients with clinically compatible signs and symptoms of TM7 and positive KOH, or clinically compatible signs and symptoms and an epidemiologic link to the outbreak. Suspect cases are patients with clinically compatible signs and symptoms with no fungal culture growth or no specimen collection. As of this week, we have 13 confirmed, 9 probable, and 13 suspect cases for a total of 35 cases in the state. All of these so far have been within the metro area. I will mention that 2 of our laboratory confirmed cases that had fungal isolates genotyped as TM7 were negative on KOH prep tests. Providers report that when patients present to the clinic after using an over-the-counter topical antifungal, specimens were sometimes negative on KOH prep tests. This epi curve shows confirmed, probable, and suspect cases identified in Minnesota by rash onset date. The first suspect case reported symptom onset in May 2025, and our most recent cases had rash onset dates during late December through January. So it looks like we're continuing to see transmission, but we identified many cases in the fall after setting up our reporting system. Among confirmed outbreak cases, all are male. The median age is 37 years. Patients ranged from 31 to 50 years. 46% are living with HIV, and 92% were on either antiretroviral therapy or PrEP. 31% were diagnosed with other STI co-infections at the time they presented with TM7. Co-infections included gonorrhea, chlamydia, and syphilis. And although we don't have complete sexual behavior data on all patients yet, among those with data, 12 of 12, or 100%, are MSM, and 10 of 10 reported multiple sexual partners. I will also add that although this data is summarized for confirmed cases only, the confirmed cases are generally representative of all probable and suspect cases that have been reported in Minnesota. And I will also add that the vast majority of cases have been reported from 2 clinics that are major providers of PrEP for the metro area. Some patients had concurrent extragenital lesions, including on the hand or thigh. This graphic shows where lesions were located for our confirmed cases. All of our confirmed cases had at least 1 lesion in the pubic or genital area. The most common area was the buttocks or perianal area, with 54% of confirmed cases having these lesions. And penile shaft and scrotum were less common. So in closing, I have a few final reminders. If you suspect TM7, collect a specimen for confirmatory testing. Send the specimen for fungal culture and contact your state health department about sending the isolate out for genotyping. There are resources available online for how to collect a skin scrape, including through our Minnesota Department of Health website, which I'll mention on the next slide. Second, remember to treat suspect TM7 empirically with oral terbinafine. Do not wait for laboratory confirmation, which can take over 3 weeks. As mentioned, CDC can provide clinical consults on specific cases. And finally, consider reporting suspect TM7 to your state, tribal, local, territorial public health department, or to CDC, and also to the registries mentioned earlier by Irina. We have identified a number of cases in Minnesota through our enhanced surveillance, but we suspect TM7 is already or will be soon in other communities, so it's really helpful to share that information with public health. As part of our response efforts in the state, the Minnesota Department of Health has compiled resources on the Health Department TM7 STDs webpage. There is an informational page for the public and for health professionals. The webpage also links to a 2-page printable clinical guideline that was developed in collaboration with local providers. And although some of the guidance for reporting is specific to Minnesota, most of it can be applied more broadly. I'll also mention that we at the Minnesota Department of Health are happy to share any of the other materials we've developed or chat in more detail with others about our response efforts, so feel free to reach out to me directly. And I want to say a special thanks to the providers at our STI clinics who identified the first cases and have done so much of the work to develop clinical guidelines, treat patients, and get the word out through their networks. So collaboration with providers and with CDC was incredibly important to do all of this work. And I'll also thank the rest of the MDH team, our lab colleagues, and Hennepin County DIS who put a lot of work into this response. The American Academy of Dermatology also has a lot of helpful resources on TM7, so definitely check out their webpage. And as mentioned earlier in the presentation, the notes from the field on the New York City case series and the paper out of France are also very helpful resources. So I think that concludes our presentation. I'll hand it back over to the moderator.
Great. Thanks so much to all of our speakers. So now we'll transition to the Q&A portion of this session. Just a reminder, there are some questions that we'll review, but if you have additional questions, please enter those in the Q&A box, not in the chat. So we will start. For the first question, we do not have access to molecular testing at our facility. So how can we confirm suspicious cases? As a two-part question, and the second part of the question was, do case reporting for the registries require molecular confirmation first? And Irina, could you handle that one?
Sure, I'd be happy to. So for the registry, you can report if you have suspect case. It doesn't have to be mycologically confirmed. And, we're in an evolving landscape with the mycological testing. So I think the best way to figure out where to send it and who has capacity, because a lot of labs don't have this capacity, just reach out to us at either fungal@cdc.gov or the fungal consult@cdc.gov. And those mailboxes are regularly monitored, and we can assess the landscape and get you where you need to go and help you out with where to send it. So thanks for the question.
Great, thank you. For the next question, this pertains to fungal culture testing. Jason, I'll ask you, do state labs offer fungal culture testing for those who are uninsured?
Yeah, so I think it's going to depend on the state you're in, obviously. So some will, some won't. It is relatively cheap, not the molecular part of it, but just the culture part of it. And so many sexual health clinics will have the ability to do it. Many other local clinics and FQHCs will have the ability to at least do the fungal culture testing, even if they don't have the resources to do the molecular typing after that.
Great, thank you. Next question also pertains to diagnostics for Jason. Will most labs go on to do DNA sequencing for TM7 if the initial fungal culture looks suspicious for it?
Again, it's going to be really specific to your lab. Our clinical lab will send it on to New York State DOH for sequencing if it comes back as trichophyton. Other labs will stop there, and you may have to specifically request that they pass it on for further testing. One big thing that I like to remind people is, when I present, I'm presenting the optimal world and what we could do if we had unlimited resources and could do whatever we want. None of this should stop you from providing therapy and treatment to patients. For patients who are coming in with a history suggestive of TM7, a clinical picture that looks like TM7, we do the best diagnostics we can, but make sure that they get treated and then treat them clinically.
Great, thank you. For the next question, this one's related to transmission. Irina, if you don't mind. Given TM7 is often itchy, is auto-inoculation or spreading into other parts of your body, is that possible?
Yes. So I'll just give a shout out to our colleagues in France who did that nice case series. Most of the lesions started in one area and they developed several others from that. So yes, it is possible.
Thank you. Next question relates to clinical management. There was a question for you, Jason. If there's a lot of discomfort, can you give topical steroids with oral terbinafine?
I would really avoid topical steroids at all costs. The early data that we have suggests that topical steroids will make it worse and spread. And it's already very hard to treat, requiring prolonged treatment. So I would avoid topical steroids if you can.
Thank you. Another question related to transmission. I'll ask both Emily and Irina to weigh in. Are there concerns that this could be spread in situations where people are living in close contact? For example, dorms, people in shelters, and others. Emily, I guess in your case, are you aware? Have there been concerns? I think in the investigation there, and Irina, similarly, have you heard? Are there concerns?
Yes, so we are still investigating, so I can't report, that we have any examples where that's definitely happened, but it is a possibility because, there environmental transmission is possible through shared towels or linens, as Irina talked about. I don't know if you have anything else to add, but that's part of the reason we're, doing this more thorough investigation is to figure out more about transmission dynamics.
Yeah, I think that's a great answer, Emily. I guess I just would add, while we don't know the exact duration that trichophyton can stay on the surfaces, fungal spores in general are very resilient and they can hang out for several weeks and months. So any large area where you're going to have a lot of shared items, that could enhance transmission.
Thank you both. We had another question about clinical management, a follow-up, I think, to that first question. Jason, what do you recommend for symptomatic relief if patients are having a lot of itching and discomfort? You want to avoid topical steroids?
Yeah, we haven't had a lot of luck with stuff because we're avoiding topical steroids is normally what we would use in there. We've tried some medications for itching and they haven't really improved anything. Just trying to keep it covered and just try to encourage people to avoid scratching it. But we've not found any sort of symptomatic management that's been particularly effective right now. But getting people started on treatment quickly and the right treatment quickly does help lead to pretty quick improvement in symptoms. So I think that's going to be the biggest portion of this.
Great, thank you. And another question pertaining to diagnostics. Someone asked, looking at the LabCorp test menu, there are two tests for fungal culture, fungus mycology culture, or fungus culture with stain. Both say turnaround time is 30 to 42 days. Thoughts about which one to order?
Yeah, so LabCorp actually has a specific dermatophyte culture. So I would order the dermatophyte culture, which is specific for what we're looking for here, and you can do it off the skin like we were talking about earlier. Remember that the 30 to 42 days is how long they'll hold the culture for. Does not mean it takes that long to get a result if it grows faster than that. But this goes back to what I was saying earlier, where fungal cultures can take a long time to grow. So they do hold it for a long time, but we'll report it out if it starts growing.
Great, thanks, Jason. And on a related note, another question around diagnostics. Can you review how to collect a fungal culture? And do you know if Quest Lab can perform the test? And just a brief shout out to Minnesota. Emily had mentioned these two websites pertaining to TM7. The one for healthcare providers has a really nice step-by-step for doing that. But Jason, if there's any tips, as a clinician that you think would be helpful to emphasize here.
Yeah, there's a couple things. One, there's a lot of great videos on the internet. I know people hate to hear that, but there are a lot of great videos on the internet about how to do this. The other thing I'll say is that when we started seeing cases in New York, we asked one of our dermatologists to come to our noon conference and actually do a conference on how to do these scrapings. So I think that if you're in an academic center, you have a relationship with a dermatologist, asking them to come perform a training can be really beneficial. If that's not available, the Minnesota resources are great, and there are lots of great videos online on how to do it. Essentially what you want to do is you want to wipe the area with alcohol and let it dry. And then you're really scraping with either a 10 or 15 blade into a sterile container and sending that for the culture. So it's actually much more simple than one would expect, um, and pretty easy to do. I know someone asked about whether Quest can do it at their site. My suspicion is probably not. They're fairly limited to mostly phlebotomy that they can do at their sites, and so I suspect they cannot. The patient will probably need a clinician to perform this test.
Great, thank you. Pertaining, I think, to epidemiology, also clinical, So I may open this up to a couple of you if you want to weigh in. I think both, in the Minnesota investigation, also Jason, your experience, have there been any associations with doxypep use? Anything further to elaborate on that? I guess Emily,
It's
yeah,
not something that
I'll
we
go
looked
first.
at in these, it's not something that we looked at in these cases. So I don't know.
Yes, I'm not aware of that in
Thank you both. Um, Jason, question, does being HIV positive or living with HIV, play a role in acquiring TM7?
So as we don't have enough data to really answer that question yet, we didn't see any evidence in the data that people with HIV were more likely to acquire TM7. I would suspect that people with advanced HIV and lower CD4 counts may have a harder time clearing it because of, the immune system. But we don't have really any data on that so far.
Thank you. Um, a question, Jason, on clinical management.
Mhm.
Once a patient is started on oral terbinafine, when can it be anticipated that there will be no new lesions?
Yeah, I don't think we fully know that yet. The data that we have from the cohorts in Europe suggests that people saw significant improvement after the 2 week mark. So I would say after 2 weeks, you would definitely not expect to see any new lesions. I would say probably after the first week, you still wouldn't expect it, but the data we have suggests significant improvement after 2 weeks, even if resolution is not until people have been treated for 6 weeks or greater.
Okay, thank you, Jason. Um, Also related to clinical diagnostics, I think with asking for more clarification around culturing, asking is the first thing to do then scrape the skin? Does this require a special container or dish? I know the resources out there specify, but if any of you can chime in.
Yeah, so any sterile container does work. We use a sterile blade, so a 10 or 15 blade, whatever we have around, and then scrape it into the sterile container, and that's it. But any sterile container is considered adequate.
Awesome. And still ready for you, Jason. Sorry. If the fungal culture comes back negative, or with an easier to treat dermatophyte, do you continue the patient? In your experience, have you continued the patient under terbinafine until symptoms resolve, just in case, or would you switch to another treatment?
So dermatology has made me a lot more comfortable with using terbinafine than maybe I was 2 years ago before this happened. If patients were improving on terbinafine, I probably would keep them on it. It is relatively safe, and people do very well on it. Dermatology seems to be their first line treatment, and so I'd probably keep them on terbinafine if they were clinically improving.
Great. And a related question for you, Jason. Are you monitoring the labs typically when patients are on terbinafine?
So I do LFTs up front, and then I do them at 1 month, and then every 4 to 6 weeks after that.
Great. I know a few people specifically asked about that, so thank you for
I will
clarifying.
say there isn't really a great evidence base for when you need to do it, but the side effect of terbinafine that we do worry about are abnormal LFTs. So I do it about every month because that's also when I want to see the patients. As we talked about earlier, we want to treat through 2 weeks after resolution. And so I really do want to see the patient about every month so I can take a look at it and see how they're improving and whether it's resolved.
A question that I'll ask for both. Jason, if you can weigh in on your experience, and also Rena, if we know, how long typically are patients recommended to avoid, close contact, skin-to-skin contact after treatment has been completed?
So after treatment has been completed, I don't think we recommend that they avoid anything, to be honest. The idea of treating them so long is that it's more than fully resolved by the time we stop treatment to prevent recurrence. And so really after the end of treatment, there should be no restrictions.
Agreed. There's no lesion, we're good.
Thank you both. Um, Another question, Irene, I think this pertains to something you presented on and mentioned earlier. So if an infection occurs by contact with linens or a contaminated surface, is it possible to see a TM7 presentation that does not involve the genitals at all?
Yes, you sure can. So if you go back to the case study in France, the roommate never had any skin-to-skin contact, only had the towels, and that his lesion presented on the back.
Great. Thank you. Jason, about clinical management in response to treatment, how long does it typically take for patients to report improvement in symptoms after starting treatment?
Yeah, so the data from Europe suggested by 2 weeks, most patients would see improvement. Clinically, we found that around a week, people are reporting some improvement, although it's not, certainly they're still having some symptoms, but they're certainly starting to see it improve by then. They can notice that it's improving.
Okay, thanks, Jason. And I will say someone asked about the specific codes for LabCorp and Quest, and we can type those in. We'll have one of our experts type those in for the person who asked about those. And also someone had asked Emily about, you mentioned the 2-page paperwork concerning how to obtain samples. I presume that might have been referring to the clinical guidance. Is that the website? So we can drop those links in as well.
Yeah, I can
Yeah.
also drop that in. The MDH website for TM7 has, under the health professionals page at the bottom, resources, links to the clinical guideline.
Yeah. Yeah, those are really fantastic resources for folks who haven't seen them yet. Definitely recommend. Another question around treatment, Jason. Given limited resources at our clinic, fungal culture and sequencing not available, and most of our patients are uninsured, can we empirically treat as if it's tinea corporis with topical clotrimazole available over the counter for 2 weeks, and then only consider emerging dermatified strains if they are not responsive?
I think that's a very reasonable approach given limited resources. You know, if we start to see more of these cases, and it's been pretty limited so far, but if we start to see more of them, it may be worthwhile to sort of figure out creative ways to acquire terbinafine for patients. But I agree with you entirely that I think that's reasonable when you have limited resources.
Great. And someone asked around diagnosis. How could someone determine the difference between an infectious TM7 infection and remaining hyperpigmentation?
It's really hard. You know, what you can feel it and see whether some of that scaly stuff is gone. You know, it'll be a lot flatter when it's just hyperpigmented and no longer an active lesion. You can also do a scraping to see if it will grow. I will say that I did that for one patient where I just really wasn't sure. I actually did a scraping to see if it would grow, and then it never grew. And we felt much better about this than being hyperpigmentation than active infection. But it certainly can be hard, and you'll want to look at it, and you might want to even bring in your dermatology colleagues who can help you have a lot of experience with these types of cases. I will also say that I was just looking online to go back to the last question. Sorry, Laura.
Oh, you're
You
fine.
can get terbinafine fairly cheaply at some of the online sites, so just something to keep in mind as well.
And great, Jason, still in the hot seat. Someone asked for further clarification that you had mentioned repeat infections are more likely, or if there's clinical worsening or new lesions, most likely treatment failure rather than reinfection. Could you further clarify, is that based on DIS work or partner services or other information?
Yeah, it's based on the DIS work from Europe. They did not see a lot of reinfection, but there was a lot of recurrence in patients, especially those who would stop treatment at the 2 week mark and even the 4 week mark, and for people who stopped treatment before it was fully resolved.
Great, thanks so much.
Mhm.
Emily, there were a couple questions pertaining to the Minnesota investigation. One individual asked if the Minnesota outbreak included folks with TM7 had any lesions on the face. I didn't see that listed as a site of infection, if you're able to.
Yeah, no, we haven't in any of our confirmed cases, and we're still kind of collecting more detailed information on the probable and suspects.
Okay. And I think someone also was asking pertaining to the epidemiology so far of the cases there, to clarifying if there have been any women who have tested positive or have been treated, and there have not been so far. They wanted to clarify.
No, yeah, no women in
Okay.
Minnesota.
Great, thank you. Just scrolling through to see the next ones. Jason, a clinical question, thinking more about the empiric treatment in someone whom you suspect some sort of tinea infection. I think because of the fungal culture, confirmation of TM7 can take a very long time. Would you advocate for STI clinics ever starting empiric terbinafine concerned that it might be harder to sell that without a confirmed diagnosis, but just thinking like kind of realities,
Yeah,
upfront.
I do. I actually think that we need to be, when we have patients coming in with genital lesions that look like they could be dermatophytes and look like they could be TM7, I think we probably should be starting with empiric terbinafine to get people started on treatment, especially given the amount and the duration of treatment they need. It doesn't make sense to wait 2 or 3 weeks for your culture to come back.
And related, pertaining to whole genome sequencing, someone asked when would be a good threshold to order molecular sequence testing, which sounds expensive and has a long turnaround time to the reference lab. Would it be very low yield? I think concerns about if, ordering it too often, potential consequences of that.
Yeah, I think it depends on who's doing. If your state lab is willing to do it for you, they often don't charge, and so that's awesome. If you can't do it that way, then I would reserve it for patients who are not improving on your current th treatment to try to get a better understanding of why they're not improving.
Thank you, Jason.
I'll just add, contact your state health department and they should be able to work with Wadsworth. We do that at no cost to the patient, so that shouldn't be a holdup.
Great. Thank you, Emily and Jason. A question for Irina pertaining to surveillance. Someone asking, are there plans to stand up a surveillance network for TM7? Essentially calling, for labs to submit isolates for antifungal resistance testing or genotyping and overall surveillance of circulating genotypes. Many labs ID this, but don't have the ability to sequence.
That's a great question. I think right now we're looking at a lot of different options, but I think there's definitely an interest of learning more about what's circulating and what we're seeing in the United States. So looking at different options, and hopefully we'll have some more information to share at another time.
Great, thank you. Jason, pertaining to clinical management, again, do you stop treatment once all lesions are cleared, or is it a set time frame, or how do you approach that?
Yeah, so usually 2 weeks after all lesions have resolved is kind of what we say. But we do want to make sure that all lesions are resolved before we even consider when to stop.
Thank you. Um, let me see. One question for Irina, and I know Minnesota touched upon, I think, some of this in their clinical guidelines, but asking, can TM7 be spread by objects? Asking specifically about toilet seats, but I think in general, thinking about fomites. And is there anything proven to clean the surface?
Yeah, so they can hang out on a lot of different surfaces. I'm just looking at my notes so I get you the right information as to how to clean it. So if you have a concern about fungal spores, they can be killed with common disinfectants, like thinking about diluted bleach, benzalkonium chloride. I hope I got that correct. This is another disinfectant that's typically used for cleaning hard surfaces or other strong detergents. So like items that might be a little bit more challenging, so thinking about razors or sex toys, you can soak those in a bleach solution, and that should hopefully get rid of any fungal spores that are hanging out.
Great, thank you. Jason, another clinical management question for you. Does symptom resolution indicate cure? Is a follow-up culture necessary? Presumably if they've otherwise
So I'm
healed.
going to separate those questions out. So clinical resolution or symptom resolution does not necessarily equal cure. We had many patients who within the first 1 to 2 weeks, their symptoms mostly resolve. But that does not mean that their lesion is fully resolved, especially when you look at it and it's still there, it's still raised. Um, you do not need to do a repeat culture. It's usually in patients who don't have the hyperpigmentation, pretty obvious when the lesion is fully resolved and their skin goes back to looking like it did before. I think it can be most helpful in patients who do have some hyperpigmentation and scarring, where maybe it is a little bit more challenging, where it is a little bit more challenging to determine whether it's fully resolved or it's just hyperpigmentation. And that's where I think there's a benefit to repeat cultures.
Thank you, Jason. And there are a couple questions pertaining to other populations and the treatment in those populations. One question, in case there was a pregnant person with suspected TM7, Jason, thoughts on potential treatment options? And someone similarly asked, if there were, potential children, thoughts as a pediatrician as well.
Could you ask the first part of the question one more time? So I got the second
In
part.
pregnancy, if there were concerns for suspected cases in pregnancy, thoughts on treatment.
Yeah, I think we'd have to really carefully look at the pregnancy literature and then use shared decision making about which antifungals are safest in pregnancy. Off the top of my head, I apologize. I don't know which ones are the safest in pregnancy, so I don't want to answer that question. We can use terbinafine at different dosing in children, and so if I thought I had a child with it, I would use terbinafine in that way.
Um, Thank you. And I know we have a few minutes left. I think we may have gotten through most of the questions here. Jason, do you happen to know the codes for the Quest or LabCorp? Otherwise, we can drop those in the chat or send
Not
them.
off the top of my head, sorry.
That's something we'd be able to follow up with afterwards when it gets sent out. Someone asked, is there an effort to collect images for clinical presentation, particularly including, I think, diverse skin of color of skin? Jason.
Yes. We've been collecting images on our site, and I know that the NNPTC, along with the national curriculum, has really been working hard to add images to the national curriculum website. There's now an image library that's available, and there's a way for you to submit photos if you have ones that you're interested in sharing. And so I think I encourage everyone, if your patients are willing, to add images to the beta database so we have as many different appearances as possible to really help us make these diagnoses.
Yes, and I'll also put another plug in for the NNPTC STI image library, and we'll send that link out, I think, with other resources if you haven't seen it yet, and hope to build that out to include more images. So thank you. I think we may have gotten through all of them with just 1 minute left. So if there's nothing more, and I see we will send out those resources as mentioned, but just wanted to thank all the presenters. Thank you all. Those were really fantastic questions and it was a really great session today. So just thank you all.
Yes, thank you to all our presenters, Laura, to you, our moderator, for the questions. We will have the recording available next week, and we will send some follow-up information, as mentioned, with the image library and a couple other resources mentioned here. So thank you all very much, and have a great day.